All right, good afternoon, everybody, and thank you so much for being here live, and also those of you on Zoom checking in with us. I'm Hank Cardello. I direct the Leadership Solutions Program for Health and Prosperity here at McDonough School of Business in the center here. We have a tough topic we're going to go over here today, and oftentimes I find myself in the middle of industry, consumer issues for certain problems like obesity, trying to come up with solutions. This one's a biggie. This is a real serious issue. You've heard a lot about the tuition debt problem that's been in the press recently. And there's a lot of differences between what's going on there or just regular loans that consumers take out. This is a rather unique animal that we have to deal with. And we're going to talk about all the facets of it and try to bring in other pieces of the puzzle here so we can get a better handle on what we need to do to really step up and make some progress dealing with this problem. We have a real expert panel with us today, and I'd like to introduce them. The flow today is I'll just give you a brief overview of the white paper you should have a copy with in front of you. For about 10 or 15 minutes, and then we'll have a panel discussion, and I'll have some questions for our panelists. And then we'll open it up to you for any questions you might have. Also, for those of you online, if you want to chime in with any questions. But let me introduce our panelists here. Right here next to me, John McNamara is the Principal Assistant Director for Markets at the Consumer Financial Protection Bureau. John is the consumer advocate in this space. He and his team have published a landmark report this past March on the entire issue of medical debt and how it affects consumers. Very comprehensive look, and they've also published some follow-on reports looking at the impact on low-income populations, ethnic populations, and I believe in nursing homes recently.
Yep, just today.
Just today, so out news, so check that out. Also, though, John brings a background in the debt collection side, so he really understands both sides of the equation. So, like myself, John's gone over from the dark side from industry over to advocacy on many issues. I always get teased about that. So welcome, John. Thank you for being here.
Thanks for having me.
Ashwini Katwal is with us also. She is the CEO of Aretas Health. It's a company that works with healthcare providers and hospital systems to try to work with them on the revenue issues. They call it revenue cycle and collections, but she's been on the inside of the healthcare industry with organizations such as UNC, Rex Healthcare in the Research Triangle area in Raleigh-Durham. She's also been a CFO for several organizations, and she originally started at Ernst & Young. So she brings that background also on the financial side. And then over at the end here is Mark Dietrich. Mark is the CEO of Capio LLC. They are a non-performing asset acquirer. They deal in debt collections. Mark's been in this industry for several years, and he's going to help us provide those insights from that side of the equation. So really, we have the consumer side covered, we have the healthcare side covered, and of course, the collection side covered. And we wanted to bring those perspectives into this. And I just wanted to mention also, as with Ashwini, Mark, instead of starting at Ernst & Young, started with PricewaterhouseCoopers and auditing. So again, you have financial types here dealing with the issue along with people with consumer perspectives. So what we'll do now, also, by the way, before I forget, I did want to give a call out to Annie Marino, who couldn't be here. She's on watch for COVID right now, so she's listening in. She was a terrific help to me on this report as a research association. So I wanted to call her out for all her good work. And also want to thank all the staff here at Georgetown Business for Impact. Everybody's been terrific. Also, I'd like to say hi to Leslie Crutchfield, who's the head of the Business for Impact Center here at Georgetown, sitting right up here. So thank you for coming, Leslie. All right, so let's dive into things. I want to briefly talk about Business for Impact, what we do and what's different about it. we believe that business can play a major role in addressing these major societal problems. They're not going to solve themselves without involving the people who are involved in the middle of it. All right, it won't happen. You can't just edict changes on a major industry like this. And this is a labyrinth of problems. You have a lot of players, you have healthcare companies, debt collectors, you have insurance companies, on and on. You have uninformed consumers, for lack of a better term. And our belief is that companies will succeed by balancing the needs of all the stakeholders. In other words, we look for win-win solutions. All right. We also believe that industry needs to step up and take leadership stances on these hard issues. All right. And by that, for two reasons. It's the right thing to do. It's also good for business now. Okay. I couldn't say this 20 years ago, but right now, doing the right thing is actually good for business. Okay. It makes sense. And I also like to add in, it also adds a little bit of degree of inoculation to the industry by getting ahead of it. The freight train's on the track on this issue as far as regulations, et cetera. So organizations that get ahead, think progressively, think about what the consequences of any actions are and get ahead of it will do well. Those who don't, there's that freight train. It's a big freight train. Again, we've seen it in other categories, again, like the obesity issue. So let's talk about the purpose of the white paper. You should all have copies of it in front of you. We wanted to look at it, as I highlighted, we're looking at 3 different sectors here, covering consumers, healthcare systems, and collection agencies. And also, we're trying to search out what I like to call middle building solutions, win-win types of solutions, where we not only want to deal with the short-term issue of medical debt, but in a broader context, how do you help the consumer get on strong and sound financial footing going forward? Okay, we don't want to think in terms of one-off. How do you fix the problem on an ongoing basis? That's number one. Number two is really talk about some of the changes we think that need to be made and considered in the collections industries. All right, there's some things that work, they're needed, but there's also some changes, and we'll talk about those later. And then finally, no one really talks about what the healthcare system needs. Shwini's going to give us some of those insights. In other words, what happens if this infinite debt never gets collected? What happens to the healthcare system? So she'll provide those kind of insights. So starting with the problem, bottom line, it's an $88 billion of medical bills are now in collections. That's not the total medical debt. This is in collections. That's a huge number. That's a real big time problem. And there's a number of distinctions, let's say medical debt versus tuition debt or auto loans or even mortgage debt. First of all, it's generally involuntary. I don't usually want to go in for a triple bypass. Okay, this is not on my top 10 list for something I'd like to do over Labor Day holiday. I have better things to do than that. Also, those who are unable to pay their bills and are dealing with the stress of collections, they run into health issues. We'll show you some charts momentarily. All right, so it doesn't end with the debt itself. It also causes additional health problems. Third thing is price transparency. Unlike when you go to a grocery store, I know what I spend for an item. It's right in front of me. In this case, no one really has a good handle for what the hospital bill is going to look like. It's like this maze. All right, where does it come from? And not only what the bill is, but all of a sudden there might be 6 different constituencies: hospital, anesthesiologist, the cost of radiology, et cetera, et cetera. So this is again, makes this complicated. And then the other thing is, unlike, again, like for a mortgage where you go through this whole rigorous process about qualifying for your mortgage loan or an auto loan, there's no qualification here. Okay, you have a problem, you're in the hospital, you get serviced. All right, and no one knows whether you are able to pay for this or not. And then finally, what we'll talk about now is we've identified what we call the Alice consumer. I'll describe the Alice consumer. And generally, these are folks that if you break down income strata, into quintiles. There's a kind of like the second lowest quintile there, where they're above poverty, so they don't necessarily get the benefits, but at the same time, they're struggling to make ends meet. Okay, they really struggle big time to make ends meet. So what does it mean? What does ALICE means? Asset limited, income constrained, yet employed. Many of these are the essential workers we've been reading about through COVID. Okay. And some of them will work in 2 jobs, even in some small number, 3 jobs. All right. They're above the line, but they can't make the ends meet. And they don't really fit into the mold of getting benefits and other programs. These guys get hit real hard. They get hit big time hard. There have been studies out there that say, for instance, almost half of Americans can't handle a $500 bill, whether it's a debt or some other surprise bill that comes up. They can't deal with it. All right. These folks come into that category. I actually had a story I shared when I went for a haircut last week. And I was just mentioning, we were having the session here today, and the gal was cutting my hair, said, yeah, I went in and they found out I had kidney stones, and the radiology was $2,700. I pay $300 a month religiously, and I get hit with this bill for $800. And that hurts. That hurts her big time. It came out of nowhere. That's the kind of insidiousness that's happening with this particular problem. So it's really at the out-of-pocket and the high deductible arena where we're seeing this problem. And we mentioned it was bad for health. In a study that we conducted, we saw that these are the kind of things that consumers are telling us. What's happening is, well, I have medical debt. I'm not going to the emergency room, or I'm not going for my normal checkups anymore. Or what's really scary, a lot of them are skipping their prescriptions. Or in the case of diabetes, I'm not getting insulin. Okay. And all that does is beget more health problems. So again, it's not just a one-shot deal. It permeates, it continues to go. So when we break down the drivers of medical debt, these high deductible plans, out-of-pocket costs, they're kind of nickel and diming Americans into debt. And again, we mentioned people just don't have enough in reserve. A huge chunk of our population just can't handle this. There's also issues of price variability, lack of transparency. Again, there's even though pricing might be published, people are not oftentimes planning to bump into the wall on what medical expenses might be. And then on top of that, there's a lot of inefficiencies, miscommunications. You ever see at the end when you check out, they code your visit. All right. So is it properly coded? Or is it coded to a higher cost level? Again, a lot of that is real loosey-goosey. So, and also the communications about practices that hospital systems have, that they're not really clear. And there's a lot of cases where they don't check to see if somebody even qualifies for charitable help in their healthcare. So a lot of these things aren't happening. Now, flipping the coin, if you're in a healthcare system or with a medical provider, they need revenue. And I believe, Ashwini, you were saying that they're losing 10 to 15% of revenues potentially never being collected, or at least they have to try to recapture. Their margins are very low. And in some cases, someone did a study over through COVID that actually a number of the hospital and healthcare systems are now in the negative profit margin arena. So they're not making much money. So their risks are a reduction in services. Okay, and also some of them may go out of business, especially in the rural areas. And we're finding out that in rural hospital systems, some of these are going out of business. Now people have to drive 10, 20, 30 miles just to get to a healthcare facility. All right, so it makes it a lot more difficult for people already who are struggling to get good healthcare. Now, one thing that's important to understand before we get into our panel discussion is what goes on with this medical debt collections? How does that work? Well, the healthcare systems and the providers need help. First of all, some of them, the hospital systems themselves, will go out on their own, or they contract somebody to go out to follow up and try to collect on what's due in the name of the hospital or the healthcare provider. Okay, that's called early out or internal. All right. Then there are those that are more contingency. In other words, they work on commission. All right. And they work in their own name. All right. Not necessarily in the hospital's name. So in some cases, they have their own name, but they may or may not have the records, medical records, where they can describe to the consumer or the patient exactly what's involved in the collections. And then finally, there's a minority, non-performing asset acquirers, where they actually go in and they'll buy the debt at a big discount, but then they own the debt. So it's up to them to figure out how to work with the patient and probably have a little bit more flexibility how to do that. So with that as background, you have a number of new rules that are showing up. And again, these are articulated in more detail in the white paper in front of you, but the national credit reporting agencies came out, and effective as of July 1st, any medical debt that's paid in full is going to be removed from the credit report. So it doesn't stick on there like a big red flag any longer. So it's removed. Secondly, anything new that's still unpaid won't be added to credit reports until a full year after it's submitted to collections. In other words, the unspoken word is, again, oftentimes it takes forever to try whether bills are being challenged or it goes through insurance. And next thing you know, you're 6 to 8 months out and you still don't have any idea what the bills are. So it's trying to address that. And the third thing that they've agreed to do is effective in January, any unpaid medical debt balances of $500 or less will be removed from the credit reports. In other words, they won't show. And that may have a big impact. And John, you may want to touch base on that from what you've seen on your research. We're seeing that the average debt actually is not a mega amount. Yes, there are some large medical bills out there, but most of them are really falling in 500, 400, 600 range. And then there's a host of new legislation. I won't go through it here. Again, it's articulated in the white paper, but things like No Surprises Act, where, for instance, if you go in to a hospital for a procedure and all of a sudden the anesthesiologist is out of network and you're surprised, wait a minute, why am I paying all this money for an anesthesiologist? I went to the hospital in my network. So this removes some of those kind of surprises. Also these are a combination of federal and state regulations that are out there, like trying to be more transparent on the pricing and Medicare expansion. We've seen that in the states where Medicare has expanded, the medical debt load doesn't seem to be as high. So that's a consideration. And other things they're looking at, things like interest rate caps. In other words, you don't want anything usurious out there. These people are struggling to pay the basic bill, let alone tack on some big interest rates. So instead of the usual recommendations page, in this case, we'll call them prescriptions for our problem here. And we'll break it down into 3 pieces. Number one, let's talk about what we believe hospitals and healthcare providers can and should be doing based on our assessment of the problem. Number one, transparency, transparency, transparency. Okay, the consumer is confused, help the consumer, lay it all out, give them a menu, help them understand. Number one. Number two, we think there's an opportunity as they work with those who collect on the medical debt to ensure that the ones doing that follow certain standards and procedures. Okay, don't make it open-ended. Just don't say, go get the debt. I don't care how you get it. No, we're not recommending that. We're saying set up some standards here so you can treat the patient humanely, work with them, make sure it's affordable. And then finally, we recommend that they work with private industry and credit reporting agencies, okay? Bring in technology now. There are some products out there right now. We're looking to try to help. Our recommendation is let's not be one and done here. Let's try to help the consumer, number one, address their immediate medical debt problem, but more importantly, help them get back on their financial footing. Okay, if they can get back on their financial footing, this problem goes away. And if you really look at it, our GDP in this country is driven 2/3 by consumer spending. These people can't spend anymore. They're out of the loop. So bluntly, selfishly for the country, if you get these people healthy, all right, they're back out spending. Right now, they can't. They're underwater right now. For the collections industry, our call is to apply fairer terms to our ALICE patients and ALICE consumers. And to do that, we really think that the industry needs to aggressively self-regulate. As I mentioned before, as we've seen in other industries, freight trains on the track on the regulatory front, and it's not just federal, it's also state. So this could be a whole calico collection of regulations that show up that could really, really hurt the industry. So get ahead of it. Get ahead of it. You know, any practices as it relates to lawsuits or wage garnishments, you know, they need to go away. Also need to be better screening to identify if somebody really can get some charity. A lot of people don't know they even qualify for charity. They don't know. They don't know. So if nobody tells them, they think they owe all this money, and then they might be able to get some relief. Any charges over and above the bill, the basic bill, you know, like fees and high interest rates, again, we think those need to go away. We also think that looking at affordability, the ability of the patient to pay is important. You know, so for instance, a small percentage of what their income is. You know, as an example, the tuition bill now that used to be at 10% of income, president's bill, now capped it at 5%. One of our thinking is that, okay, you got to think about it though. Some of these people, as we see, you know, have a lot of debt. So if you have 5% times 4 or 5 forms of debt, that's a lot of money of your income that you don't have in the first place to pay. So we have to consider that. And then we also recommend prohibiting debt buyers from reselling to other debt buyers. It goes down the chain so far that, again, consumers don't know. They don't know what the connection is of their expenses back to the source. And then we think the collections industry needs to educate and assist the debtors so that they can affordably help them get rid of the debt. And again, we're big on long-term financial stability and provide some tools in the form of apps and other tools that can help the consumer. I mean, that's where the younger generation is going. That's what we need to do to leverage for consumers. And then finally, for policymakers, I'd like them to consider to establishing affordable payment solutions. You know, put a ceiling. All right. As an example, as I was just alluding to, 40% of those in debt and collections have 2 to 5 collection accounts. So if you have 5 collection accounts and each one you're saying, well, all right, you can pay 5% of your income on that, you're up to 25%. And I can't make ends meet to begin with. So how am I going to fix the problem that way? So that has to be considered. Secondly, I think there needs to be caution to lawmakers about preventing the healthcare providers. There needs to be a balance here because they're in trouble on their revenue side, that 10 to 15% number we talked about earlier. They need to somehow recapture that lost revenue because of the loss in service or even closing down some facilities. And then finally, we think policy members, just like they're helping people with tuition debt, need to specifically step up and see if we can help these ALICE families because they're in no man's land. All right, they're in no man's land. They don't get any benefits and yet they're struggling, working 2 or 3 jobs. They need some help. They're underwater. So with that as background, and by the way, if there's any questions, I'll leave this up. If you want to reach out to panelists afterwards, here's my email here at Georgetown, and you can send your questions in and I'll make sure the proper panelists get the questions. But with that, we'll have a panel discussion now. We'll talk about these issues. We'll get down into detail. And afterwards, again, we'll open it up for your questions. So again, panelists, thank you so much for being here, listening to my propaganda. But we need your help. And we need your insights, and that's why you're here. And John, I'm going to start with you. You came out with this landmark study in March, really did a pretty good in-depth dive into this problem from the consumer perspective, how it was hurting the consumer. Perhaps you can just elaborate on that study, some of the key findings, and more importantly, what that might mean for addressing the problem.
Sure. And Hank, thanks for inviting me and thanks to Georgetown as well. And I'm going to really show a lack of grace by correcting you. You referred.
You're not the first one.
You referred to me as an advocate, but just make no mistake, the Consumer Financial Protection Bureau is, among other things, a law enforcement agency. So for those who don't know or are not familiar with the Consumer Financial Protection Bureau, I think Senator Warren's given a lot of credit for sort of ideating this thing that would be akin to a product safety commission for consumer financial products, because they're complex, they really hurt consumers. And then in the aftermath of the Dodd-Frank Wall Street Reform and Consumer Protection Act, the Bureau was formed in 2011. So we have rulemaking authority, we have supervisory authority over many entities, enforcement authority, and then we also do a consumer education function. My team of about 40 people resides in the research, markets, and regs area. We're sort of a self-contained policy and rule writing shop. So we are former industry players. I was a debt collector for 30 years. I collected medical debt. I furnished medical debt collection trade lines. But when we undertook this report, we wanted to use our own research as well as curated research to tell sort of a fuller story of what it's like. And as we at the Consumer Financial Protection Bureau think about consumers at risk, typically low, moderate income consumers, like medical debt is everywhere. And that's why the team really wanted to key on this. So some of that research that we did ourselves was based on our consumer credit panel, which is this awesome database and resource. It's a de-identified roughly 1 in 48 longitudinal. By longitudinal, I mean, if we've got a consumer from 20 years ago, we can follow what they look like in terms of their credit life all the way to the present. So we used that, and we found that there was roughly $88 billion in medical debt on credit reports. And I want to make this clear. If you're late on your Citibank card or your student loan payment, not direct loans, but say, SoFi or a private student loan, if you're 30 days late on that, that owner of that debt is going to furnish that as late. Healthcare is so different and weird in that the healthcare providers, I think our own research showed that 99.6% of these trade lines were furnished not by the provider, the person that owns the debt, has the system of record, but by a debt collector that either agreed to do it for them or was contractually forced to do them. But anyway, we found out there's 88 billion out there that we can see. We know most healthcare providers don't require collectors to furnish and don't furnish themselves. So the number is probably a lot bigger. Touching 43 million consumers. And we had another thought is, can we see if there are apparent racial disparities or other things going on with this debt? And we were able to find out that disproportionately, these debt collection trade lines are marking up the credit reports of Black and Hispanic consumers, low income consumers. And then we had another thought. We thought, wait a minute, we know that the scoring companies like FICO and VantageScore, like for instance, the mortgage industry relies on older versions of FICO that actually take into consideration medical debt. We thought, wait a minute, if there are a disproportionate number of Black and Hispanic consumers in this stuff, we know that both FICO and VantageScore have over time started devaluing medical debt. And guess why they're devaluing it? Because it's not as predictive. It's not as, the whole system is designed to predict the likelihood of default when you're underwriting a loan. Over time, they stopped doing that. But if you tried to get a mortgage and you were Black, you were more likely to have one of these debt collection trade lines, and you may have paid the price, which is sort of an awful thought. So we looked at that, and then we saw regional differences too, in that states that didn't expand Medicare disproportionately, we saw that consumers in the South were affected. And then on the secondary research, we looked at like what doesn't, as we're ideating this thing, we're like, what doesn't it hurt? And pretty much it hurts everything. It hurts, mental health. We found evidence of that. Physical health. You referenced, I think we found that in one reputable study, 46% of the survey folks reported that they basically skipped medical care because of medical debt. 41% said they skipped prescriptions. Pretty awful. I think we found basically folks with medical debt were 3 times more likely to have mental health issues, which is, sad and astounding. So again, a really, really pervasive problem. And then the other thing about medical debt collection trade lines that I want to make clear is that people get very caught up in the score, the FICO score. Vantage Score is a scoring company that many people probably see often if you've got Credit Sesame or Credit Karma or Mint or one of the lead generators that they run on the Vantage Score. And by the way, medical debt is so probably not valuable for underwriting that Vantage Score just announced that they're going to basically, their new versions of the score won't even look at medical debt at all. They're basically saying it's not relevant to likelihood of default later. But anyway, people get caught up in the score. But the fact is, if you're a landlord and you're if you're trying to rent, the landlord is going to look at a credit report that will actually have that trade line there. It might not be baked into a score, but they're looking at it. A future employer may be looking at that and decide whether or not to hire you. They may make judgments about you by a $75 medical debt that you don't even know is on your credit report. And these medical debt collection trade lines were we saw them as such a problem in debt collections that I joined the Bureau originally to work on the debt collection rule. We were sort of concerned about people who own debt or furnish debt with no intention of ever calling the consumer. They would just furnish these trade lines, almost like sowing landmines in the financial path of a consumer. And when they stepped on those landmines, they're trying to buy a car, they're trying to get a mortgage, they're trying to rent an apartment, or a future employer says you've got this black mark, they would just pay it. May not even owe it, might not be the right balance, but they would pay it. So our debt collection rule says that before anyone can furnish that who's a debt collector, they have to at least try to communicate or contact the consumer so they can let them know what they're trying to do. So when we released the report, and you stole a tiny bit of my thunder, but we released the report about 3 weeks later. The nationwide credit reporting agencies, Equifax, Experian, and TransUnion, jointly announced that they were going to extend the period that this information was supplied from 6 months. They wait 6 months now, or then, to a full year to basically let insurance play out, let everything get squared away, let disputes get handled. They were going to, in the early part of 2023, balances at least 500. They might go higher. I think they used the word at least in their release. They're going to take those out entirely and just not furnish them anymore. I think that's a huge win for consumers. We did, and by the way, when we announced that, Director Chopra essentially said we're going to continue to work in this area, and we have. We've produced other studies, and we'll talk about those later. I don't want to eat up too much time. And then we would do other studies, but he also said, do the remaining debt collection trade lines even belong in the first place? Because they appear to be coercive, essentially free forms of debt collections used by collectors, not really designed to make the underwriting system more robust. So again, why are they doing that? But again, as far as the continuing work goes, just today, we released a report on nursing home collections. And if you have elderly parents, just know this. Well, to me, Hank, this is a great example of how, at the time, Director Chopra said we would work with other federal agencies to sort of, find ways to help consumers who are laboring under medical debt. We worked with the VA, and the VA announced they weren't going to furnish debt collection trade lines until they'd exhausted virtually every other collection method. And I think that cut basically 98% of trade lines that negative trade lines on veterans' credit reports. And then just today, we worked together with the HHS, CMS, Center for Medicare Medicaid Study Services, to basically using an Obama-era law, the Nursing Home Reform Act, and this is good to know, especially if you have aging parents. A nursing home that accepts Medicare or Medicaid cannot, as a condition of admittance, demand guarantee a payment from a third party, but we did find that was going on. So we worked with HHS. We announced this, and the angle for the CFPB, because we are the primary enforcer for the Fair Debt Collection Practices Act and the Fair Credit Reporting Act. Any debt collector that's trying to collect that debt that was basically an illegal balance that under the law shouldn't exist, is engaging in basically deceptive practices and therefore would be violating the Fair Debt Collection Practices Act. I think that's another example of how we're doing what we can to help consumers deal with this medical debt. And then I can get into the whole other thing. You touched on this. It's so different than anything else. It's not a discretionary purchase. The economists would talk about search friction. I mean, nobody literally, very few people go, or if anyone goes doctor to doctor. And then what's the price elasticity of a life-saving drug or treatment?
So John has articulated the consumer issues regarding this problem. Ashwini, let's look at the other side from the healthcare provider. Okay, where are they coming from? What are they looking at? What are their challenges and how are they trying to deal with it?
Sure. So from most hospital systems, I mean, I joined the industry about 22 years ago. Patient debt was not a problem. We were not thinking of patient debt. It used to be even in emergency medicine situations, 5% of our revenue would come from patients. We would send out 2 statements and we would basically at that time decide whoever paid. We didn't really look for patients to actually make a payment. If they paid, we accepted it. If not, we wrote it off. We were moving in that direction. It has now become close to 10 to 15% of revenue that most healthcare companies, as well as physicians, hospitals, patient-related balances are going up every single year. And though we say that several people, post the Healthcare Act, we did get a lot of people qualified for Medicaid, but several people went into a high deductible insurance plans. And though they came to us, like we used to say, oh, we have so much in insurance was covered. Not for those patients. It did not change. Upfront, it looks like on our payer mix that we have all this insurance. However, in reality, we are still now collecting from the patients. Few things that I want to say that, from your perspective, you're looking at it at 88 billion. So at a macro level, I'm going to go kind of at a micro level of how exactly these things work. So most of the times when you're talking about physicians who are hospital-based and are separate groups, most people, my neighbors don't believe. It's like, what do you mean you work with physician groups? Aren't they part of a hospital? No, they're not. They are all separate entities. You have your radiologists, you have your anesthesiologists, you have cardiologists. You can go and have all these services, but everyone is going to bill separately. So the first problem occurs is when the person, the cardiologist or the anesthesiologist never gets the insurance information. It literally starts with that. It's like at a very basic level, you don't have the insurance information. So what's your next step? You try outbound calling to the patient. I mean, who says normally 90%, per our data, about 85% people do not pick up phone calls. So you have to somehow find, ways in which you can engage with the patient. So you drop a bill to the patient. Most of the time, it's they wait till you get 2 statements, 3 statements. It's completely understandable that the patient believes that the cardiologist would have his insurance, but somehow they don't. Ultimately, what happens is after about 200 days or something, the patient does decide to call in. And at this point, patient is ready to give you, I have Blue Cross Blue Shield of North Carolina. Too late. You had a 90-day timely filing limit, so we could not file with the insurance anyway. So there are multiple instances. If the patient is truly uninsured, because that's normally the picture that gets up there, it's like a completely uninsured patient. A completely uninsured patient, you have so many options. You can give them a nearly full discount. You can give 75% discount. There are just so many different options you can work with the uninsured. Uninsureds normally get a lot of discount or charity, and all providers who are associated with that hospital normally carry through with the charity as well as other options. But what you normally end up seeing is that these are not the uninsured patients who are really coming into this credit bureau rating. It's the underinsured patients who always get in there. And these people normally think that, oh, look, I have medical insurance. That gives them full confidence going into the medical system, thinking that their bills are going to be paid. The doctors, when they are providing this service, they are providing in good faith. The doctors actually do not know the policy when they are providing you the service. The doctors do not know what is covered, what is not covered. Like, these are things that never get discussed, because the doctor is there to treat you. They look at your condition and that's all they do. So that it's not the doctor who decides, oh, you're underinsured, so let me try to do something less for you and give you a $500 lesser bill. It's not a discussion that happens at the time of service. And so this is what continues down the path. And ultimately, there are several errors that happen. I will accept that at the time when actually the debt is being transferred over, because hospitals are not equipped, in all fairness, with all the physician groups to directly engage with the patients at that time. There is normally a central billing office or a billing company that works with them, and they are all engaged in collecting from insurance carriers. But no one engages with the patient early on to tell them exactly what is going on. Let's get your insurance on the line. Let's get this, paid. Ultimately, it's the consumer who suffers, because then after the hospital is done sending 3, 4, 5 statements, at some point, this is not workable by them, so it gets moved to another collection agency or something like that. That's the normal practice. Many things can change in this, but this is currently what the issues are at a micro level.
And I do want to come back to what you think about that, because given that we have this problem, all right, it's real, and that 10 to 15% number, if you're trying to manage slim profit margins or actually losing money, what happens to your business or your organization if you're in the red that badly? I want to ask Mark then, given these issues, especially in the healthcare side, what's the role of a firm like Capio to work with the healthcare providers and dealing with this issue?
Great, thanks. Response to a couple of things you said. John, you said that paper was basically a longitudinal de-identified study. We did one probably at the same time. We did it in 2021, probably when you did it, because you published in early 22. And you had other stats in that paper. You had stats about what do their scores look like, what other kind of credit products do they take advantage of. Our results were super close to yours. Some of them were exact. We didn't have, I'm sure you had millions and millions of consumers. We had hundreds of thousands. Nevertheless, it was pretty interesting. Some things were different, but a lot of things were the same. And Ashwini, you mentioned the functionally uninsured, I'll call it, people who have these high deductible plans. Sure enough, the first 10 plus years of Capio, we're acquiring these accounts, and I'll tell you about that in a second. And less than half were balance after insurance accounts for people who had insurance. The past couple of years, more than half are people who have insurance. So that is a change that we're seeing, no doubt about it. So as far as how Capio fits in, Hank had a slide up there about collection agencies or people in the industry and how they fit in. We're definitely in that third category. Our competitors are collection agencies. We function in a lot of ways with the consumer like a collection agency, okay? So we're calling them on the phone and we're mailing them letters, trying to engage with them to resolve this account. The difference is we're acquiring those accounts for ourselves. So the provider, the hospital, will be paid up front. Instead of getting paid over a long period of time, they're going to get paid up front for us. That's the biggest difference. So we've been able to take that situation and focus on the consumer maybe a little bit more than you can in other circumstances, because that asset is ours. We have a longer term relationship with the consumer. So we think it's a superior product because of that. But nevertheless, that's not the point. The point is we fit in the collections industry space. We're doing those kind of things.
Well, I want to go back to Ashwini, because both of you now talked about a number of the issues. I'd like to get your point of view about what you think the healthcare providers can do. In other words, you highlighted a number of challenges, a number of problems. What do you think can be done? What kind of steps can be taken?
So number one step that I think the healthcare providers would really help is when you have a chance at the front desk to actually engage with the patient. Transparency and education at that point would be very helpful. That is something that doesn't happen. The front desk clerk is normally extremely busy person who is managing epic kind of medical systems and staring at a screen and not looking at the patient. And essentially they just take barely your insurance card and scan it, most of the time incorrectly. I will say that because I've seen it all on the back end. I recently had a situation where a front desk clerk was so busy and she just picked the first insurance on her drop down, which was Aetna, because it starts with the AE. And essentially because of that, some 700 people got, basically we couldn't bill for because she picked Aetna for everyone. So where you do have an actual chance to talk to the patients, engage with them, explain to them what their benefits mean, what does a copay mean, what does a deductible mean, how would they be paying for it? Most hospital systems are not in a rush to take payments. You can always say that I can pay over a period of time. It's perfectly okay. But all this is not explained at the front desk or even when you're checking out. None of it is explained. Consumer walks out of, I mean, you would not have that in any other industry except healthcare, where there is absolutely no education at the time when there is a face-to-face going on. So that would be something that would really help in terms of engaging with the patients. Also getting the consumers to fill out the forms required for Medicaid. Many of these patients who are in medical debt, if you were to analyze this data, you would realize that they actually do qualify for Medicaid under many state laws. However, there are so many complicated forms that you have to fill out to get qualified for Medicaid, and the education about that, especially in the rural areas. I mean, you know, at UNC, we used to have lots of rural cardiology hospitals, and many of those patients did qualify for Medicaid. However, the forms were not filled out. So it just becomes like one step after time. So there is a lot of patient engagement that is something that can be done. Also, the technology is such that you can reach out to patients via text now and other areas in which you will be able to do something better for them. And I think that is still, healthcare is a little slower in adopting that technology. And so that would be something that would be really helpful to engage patients via a text, going into a website where they can actually explain their situation. I don't think that is available in many, many hospital systems at this moment. And then finally, it comes down to making sure that you know your rights, as in you ask for discounts, you ask for payment plans, and those things would be actually allowed for you. However, most people are not educated about that.
So these recommendations are excellent. The key is, are they executable? I mean, is this a short-term problem that could be fixed, or is this really something that is going to take a few?
As you said, I mean, you know, these are things that I think the healthcare industry will move towards and will have to move towards, given how much of the revenue is starting to depend on the patient. It is something that new to the industry as well. The industry actually depended on insurance to pay for nearly everyone. And now they will have to change the way they think about it, and patient will be involved in the entire thing. So it'll take some time, but these are some solvable scenarios that can happen.
All right. So John, with your background, plus all the research that you've done with CFPB, you know, and listening to Ashwini and Mark, you know, how does that all tie together? You know, in your opinion, how do we make some progress here that help the consumer? I mean, when the day is done, we're trying to help the consumer without destroying the industry in the process. So what kind of thoughts do you have based on the work you've done?
Yeah, sure. Based on listening to Ashwini and Mark, one thing that comes to mind. So we're engaging, you know, we don't have regulatory authority over healthcare providers. We do over debt collectors who might furnish information or collect debts. But in talking to healthcare providers, what's kind of confounding, and I'll go all day long about what I consider a middle manager problem, because my waterfront consists of pretty much everything but mortgage. But in each of those verticals, we often see a middle manager executing something that is wildly out of touch with sort of the culture or the overall mission or what the CEO of the company wants to obtain. So in talking to so many healthcare providers now, they don't furnish. They don't make their debt collectors furnish trade lines. Some of them don't litigate. You'll hear a lot of chatter about, you know, I actually had a cousin who was a CFO for a regional hospital. He said it's the crappiest six-figure job in the world because, the cash flow CFO's got to work on working capital and worry about it 24/7, but a hospital, especially, regional, rural hospital, like it's more complicated, just like it is for the patient. I know you know that well. But you see middle managers who sort of decide that, hey, furnishing isn't that great. It doesn't really give us a lift. And I can't share it. It's not public yet, but we've had some show us data where they show the liquidation numbers for the debt collectors who don't furnish every bit as good as the ones that do. And as a former debt collector, and Mark, you're currently one, when you furnish, it's a huge amount of risk for the enterprise because you're exposed to fair credit report. There's private right of action for FCRA violations, and a class action on FCRA can be business ending. I wish more middle managers out there would talk to each other and figure out that they don't need to push these. Actually, when the Affordable Care Act was enacted, they're called ECAs, extraordinary collection activities or actions. So sales of debt, furnishing, and litigating, those are three things that if you're a nonprofit, those are tracked. When you take those measures, do you really need to? Now, I've heard a lot of chatter about hospitals that don't litigate and they seem to be doing fine. That seems to me personally less intuitively sound, but I do know of hospitals where the middle manager does not allow furnishing, doesn't make their collective furnish, and their cash is flowing as well as any other provider. I just wish that would spread out. And as a matter of fact, I was talking to somebody who's done more of this sort of walkabout than I have, and they said, I can't figure out a rhyme or reason. Because I kind of went in thinking that rural hospitals would be more likely. Well, maybe not. I thought maybe they'd be more likely to furnish because their cash flow is more viscous, right? It doesn't come in. But at the same time, that's balanced by the fact when you're an administrator, or if you're a top person at Johns Hopkins, you can have dinner at a restaurant, nobody knows who you are. But if you're a rural hospital that sues or furnishes debt collection trade lines, you can't eat at the local Chili's without somebody recognizing who you are. I thought that reputational risk would drive stuff. Still can't figure out a rhyme or reason. But I think that there are a lot of hospitals where their cash flows are fine and they're not furnishing medical debt trade lines. And again, I'll go back to this. For some debts that's often so small and so unavoidable to have such a profound impact on a consumer's life, it's an abomination that information is furnished that might be incorrect or wrong. And there's one last thing since I'm talking, and I think this is a huge risk for debt collectors. And you know this better than I do, Mark, but hospital accounting systems, their ability to provide an accurate balance on a regular basis is I would say often sketchy. And if you're a debt collector furnishing inaccurate information, or should know that you're furnishing inaccurate information. I mean, I'm not an attorney, but that sounds like a Fair Credit Reporting Act violation. And if it's on a large scale, like that's also dangerous.
So Mark, listening to this, from your industry's perspective, what do you think has to be done? What changes would you suggest need to be made to help the consumers out, address these, what's called structural problems in the industry, given the nature of medical debt, its involuntary aspect? What suggestions would you have for the collections industry?
Yeah, so what we think is when you take that consumer mindset and you're focusing on them to be successful, and you'll draw a lot of conclusions. One of them is medical debt is different than a lot of other kinds of debt. Okay, it's not incurred on purpose, and it's pretty complicated and confusing, as everyone said here. And so you do have to treat it differently. So what we've done, and we've been advocating for, is with medical debt, you shouldn't charge any interest. You shouldn't charge any fees to the consumer. It's not unusual to charge a consumer a fee for a convenience fee or something like that. You shouldn't sue them. And as an acquirer of the debts, we don't resell them to cause less confusion for the consumer. We think those things are all important. What we're doing next, and that we think everyone should do, that we're advocating for, is if we can validate people's income, use technology, bring technology to bear, then we can come up with a minimal percentage of someone's income that should be we can ask for a medical debt. Okay, this will turn into big discounts on the balances, but it will be something that will seem fair to the consumer. Hey, okay, I understand it's a small percentage and you're going to give me some time to do it, so you'll start doing that. So these are things to help resolve the debt. And a lot of stuff on the provider side that we're all talking about will help maybe avoid some medical debts, but there's always going to be some medical debts. There's always the other reason medical debts happen is because you don't have insurance or enough money or a job or savings. Okay. So we think the next phase on top of resolving the debt is to help them avoid debt in the future. There's a bunch of core reasons why people get into debt from their perspective, not from the provider's perspective, but from theirs. Can we help them get insurance? Can we help them build their credit? Okay, so these are some things I think our industry might be uniquely qualified to help with because we've dealt with so many consumers about these things. We know them. A lot of them are the Alice consumers, and they need help in some of these areas. So we're advocating for people to in industry to try to find solutions to some of these challenges. We're working on it as well.
So if I could ask the three of you, I'll start with Ashwini. If you just have one thing you think could make a quantum leap in addressing this problem, to change from the healthcare perspective, what suggestion might you have?
So one of the things that I've always felt is that if the hospital had flexibility in terms of dealing with the consumer debt, that would be very helpful. You don't. As in, when a patient has a deductible and a copay, you cannot write it off. You do not have rights to write it off. So even if you wanted to give them a discount and you wanted to work with them, you really do not have that ability to do that because the consumer has agreed with their insurance carrier to make that copay and also to pay that deductible. If I had one thing that could change, that would really make a big difference to both the consumer and the providers, where you could offer discounts to the patients and work with them in terms of getting it paid. That would be a very big, I know it's a very big system change, but it would really help.
Okay, you think that's needed. Mark, how about for the collections industry?
So what I think would make a big difference is more things like what we're doing today. The ability to collaborate with people from different perspectives who we're all trying to address medical debt. We might have some different ideas. We might not agree on everything. And there's others too, by the way. Insurance companies, the reporting agencies, other government regulators, So if we can all, work on this together like we're trying to do today, today's been a pleasure. I think that can make a big difference. I think we'll start to see some common ground and, incrementally do some things that can make a difference in the long run.
Okay, John, final word.
Oh, gosh, it just occurred to me, like, maybe this would have been easier to say what's right with healthcare.
I know it's difficult.
And I think I'm sitting in a business school, so I'm not going to say single payer system, and that's not our world anyway. No, I think we did some research on this, and I think it's fairly immediate and fairly doable. So we didn't talk a lot about charity care, but nonprofits are required to issue charity care. And actually, this is encouraging. A lot of for-profits do as well. Perfect information and perfect flow of the dollars around charity care. Our own research showed that it appears that a lot of folks who should have qualified for charity care weren't getting it. They were still showing up in debt collection, so that the people who can't afford or shouldn't basically put this before food aren't worried about it, and they're not forgoing medical treatment because they're worried about it, that we can get those monies put where they really matter.
Okay. This has been a wonderful panel. Thank you for your expertise. We want to open it up to questions from the audience, and we have some folks running around with microphones if we need it. So please feel free to, if you could, identify yourself and your affiliation and also direct the question. And again, we follow Jesuit rules. We believe in respect, and also we expect a straightforward response also from our panelists. Yes, first question.
Yeah. Hi, my name's Colin Key. I'm a second-year MBA student here at McDonough. Thank you all for being here today. I'm curious if you could share any of your opinions on some of the, non-traditional or new care models that are entering, the healthcare space post-COVID. So thinking about like telehealth, the, importance of home health, business models like One Medical, Signify Health, et cetera, CVS. How do you think that those will impact consumer medical debt? Will it be in a positive fashion or a negative fashion?
So I can answer that. I think that they're making a huge impact in post-COVID era. Right now, several consumers who used to come to urgent care centers or particularly go to emergency rooms, which was clogging up the emergency rooms, are utilizing telehealth. And there are companies that have come up with really good solutions for that. And that is actually several employer groups are signing up with a separate agreement to have a telehealth, and it's working out really well. So generally, yes.
Is it
No,
fair,
I was
is it
gonna-
fair to say that those will probably be more affordable versus an emergency
They
room?
are. I mean, most of the time, those visits are fully covered by your employer plan. And so you very rarely have like a copay or a deductible when you're doing a telemedicine.
I was just going to add one, congratulations for almost being done with your MBA. The second thing I was going to say is the pandemic, we did a lot of time, spent a lot of time monitoring the financial institutions, large banks, small banks, car dealers, trying to learn like whether customers were suffering during this and what was going on. And even the oldest school, crustiest bankers realized their customers actually like to engage digitally. And all of our monitoring shows that has not fallen off. It's accelerating. I think that's true for healthcare, which is, again, that's encouraging, is I think more consumers will have easier, more fluid access to healthcare.
Mhm. Okay. Thank you for your question. Any other question? Yes, over here.
Hi, my name is Madeline O'Brien. I'm a health policy researcher at the McCourt School, and our team is doing a lot of research on medical debt. This was a great presentation today. Thank you for being here. And I wanted to ask, what do you think is the most effective policy action state or federal policymakers could take to mitigate the effects of medical debt, especially as it impacts that ALICE population that you spoke about?
John, you
Oh,
wanna
wow.
tackle that?
Well, first of all, our researchers would love to talk to your researchers. So make sure you get my contact information. I guess one thing that we think about, and again, this is totally not my world, but the IRS sort of certifies the nonprofit status for hospitals. And there are some hoops that they need to jump through that are very important, like how they use ECAs and their behaviors and their delivery of charity care. But on the same time, sort of the IRS has got a tough problem. You would like to make sure that they're in compliance, but at the same time, do you really want to threaten the tax exempt status of a healthcare provider when cash flows are just tough in this business? I mean, when I was a debt collector, Grady Hospital in Atlanta was one of my clients, and their cash flow came largely from Medicaid. And during the government shutdown, I mean, I sort of went through it with the CFO. It was a horrible time. So again, jeopardizing cash flows to a provider of healthcare is a huge issue. And then I'm going to hit that middle manager thing one time, even though it's not as relevant to your question. And that is just that it sometimes astounds me that an entity that prides itself on healing, on one hand, on the other hand, sort of shames.
Yeah, good point.
So I wonder if study after study have shown that the average person spends, I think it's 9 to 11% of their income on healthcare of all kinds. Okay. And then they also have the percentages of everything else, transportation and housing and everything else. All those things, due to the nature of them, they can kind of plan for. They can kind of, they can decide how much they'll spend on a car based on what they can afford. They can decide how much they'll spend on a house based on what they're going to afford. Same with everything else. But medical kind of turns into something else. So as we're trying to deploy technology to cap the percentage of someone's monthly income they should make in a payment and try to keep that as low as possible, I wonder if that can make the biggest difference, because it's something they didn't plan for. And if it skews all those other numbers, it impacts all those other numbers. That's why you hear things like not getting medical care, doing some of the things. So I wonder if something like that could be helpful.
Okay. Yes, question here. Get a microphone.
Medical debt. So, oh, there we go. Thanks.
There we go.
Eva Stahl, RIP Medical Debt. So first, I just had a couple of comments. And the first was, I was really glad you used the ALICE indicator, because what's really unique about that is the consideration of the state benefits and wrap around the individuals to provide support to really have a better understanding of their income level. And then second, I just also wanted to applaud the part of the conversation about making sure that we're assessing patients and their financial situation at the onset. I mean, we at RIP Medical Debt think that medical debt is a social determinant of health. And as we engage the health system more robustly in those conversations about social determinants, I think rethinking where we engage patients and ask those questions about their financial security is really an important part of making sure they get to the right solution, which leads to my third piece, which is a question around presumptive eligibility. So I wondered if you could talk, Ashwini, a little bit about this tool and how important it is in maybe getting people to a place of charity care that they belong. And then if you could also speak to the 10 to 15% increase in medical debt around your revenues and patient sort of lost revenue. Have you done any research, or is there any research about who those patients are that make up that 10 to 15% of revenue?
Sure. So essentially, it was actually the patients who used to have good insurance that used to pay 100% of their coverage. A lot of those patients actually lost that benefit. And several of these patients, because you can see this in the groups like, United Healthcare, Aetna, Blue Cross Blue Shield, this used to be the same groups of people who had like a $500 deductible and $200 deductible right inside that payer mix now. And it's not a 5 to 10% increase, it's a 300% increase to what the consumers are responsible for right now. It went from being 5% responsibility to being a 15% responsibility. So it's a huge increase that has happened, but it is actually within the payer mix of Aetna, Blue Cross, Cigna, like the big insurance carriers that are taken on this high deductible plan business.
That reminds me, I was talking with the CEO of a fairly large for-profit chain. And I said, what do you worry about the most? And he said, just the accelerated growth of high deductible plans. And he cited $5,200. And again, consumers sort of employers that work with insurance companies that sell the plans. Everybody feels like they kind of have insurance until they need it. Yeah. But he said that was their biggest debt collection challenge.
So I'll say something too. I'm not sure what your question is about presumptive charity, but the charity dollars are precious. And whether it's from a hospital doing it or an outside firm doing it. And so we want to offer forgiveness for people who absolutely cannot afford it. We want to offer steep discounts. So what we want to do is what we think the industry should do is bring technology to bear, not to just presumptively offer charity because you live in a certain zip code or something, but to specifically identify people's financial wherewithal. So I think doing that, and if you do the right technology, you can do it for anybody, not just people in certain areas. And so that's one thing I think the industry should be working on.
Thank you for your question. Yes, we have one in the back of the room here.
Yeah.
This is actually an online question from Hope at Program Director of Portion Balance Coalition, or she's the Program Director of the Portion Balance Coalition. She asks, acknowledging a responsibility to pay, do you have any suggestions how patients can successfully appeal seemingly unreasonable medical charges in a timely manner when submissions tend to go in a black hole of red tape? This may be Ashwini.
Okay, sure. So yes, I agree. So normally what happens is that you submit a claim about 25 to 30 days is considered average to submit a claim. And normally by the time you receive a response from the insurance carrier that this person is not eligible for benefits or their coverage terminated or something of that sort, it takes another 45 days. So you have already reached a point of like 60 to 65 days when you're dropping your first statement to the patient. So they have not even seen a bill for about 2 months or sometimes 3 months. And when you have just received the service, you are in a mode of gratitude and you want to make a payment. 90 days after the service has been received, you get a bill. That's a surprise bill. And now you thought that you had given the insurance at the time, but for whatever reason, it doesn't. So I completely agree with you that the timing on these contracts are very, very small in under, timely filing limits are 90 days. or sometimes 120 days, but that's what they give you to file these claims. So it is very short. And so presumptively sending a bill to a patient saying, in case your insurance doesn't pay, here's your bill, won't work either. So you have to go through that process currently, and that's kind of how the rules are set up. But yes, it does sometimes takes longer. So for hospital systems, billing offices, it's really good to move fast through the systems and drop the statements as soon as possible. However, it's not necessarily what is happening today in the market.
Right, yes, we have a question.
Yeah.
Oh, we have one more over here.
Way in the back.
I have one over here. Okay, let's go here first since you're here, and then we'll go to the back.
Hi, Chad Jackson. I'm in the Addiction Policy and Practice Masters program here. I keep hearing the insurance companies come up, and they're not a representative up there, but the higher deductible policies combined with the consumer paying a higher price for those higher deductible policies, and the insurance companies not coming up to speed on rapid ability to communicate information, and even probably being complicit in keeping information flow stagnant. Is there a way to engage the insurance companies in improving these policies? Is that something that could or should be looked at?
I mean, originally when the Affordable Care Act came up, this is supposed to be a good thing. High deductible plans was something that helped a lot of Americans actually get insurance that they never had before. So it was supposed to be a way in which we were insuring a lot of people who were supposed to be uninsured. However, what has happened in the market in reality, just like most of in the capitalist world, what happens is that the people who had good insurance have actually lost their good insurance that used to pay this. Employers are choosing cheaper plans that were actually made available for people who were uninsured. However, now employers are choosing to buy those plans because their premiums have to go down or other things like that. And so essentially what has happened is what used to be good insurance for good employers now has turned into insurance for their employees. That's kind of what is happening. And many employers are actually making up for it by giving like HSA contributions of $500 and all that. But these are bigger companies, like my husband works at Duke, and he gets like a good benefit where they put $500 or $1,000 in his HSA account every year. Well, that's a good thing. However, not small employers are not doing that, which means when you have a high deductible plan, you're left on your own. So yeah.
So question for John along these lines. So is there ever a potential to give relief to these Alice consumers? Again, they're really not getting any help now. Is there anything potentially on the horizon that might be done to help these folks?
It's a good question that I really can't address. I mean, the Bureau, CFPB is going to continue to work on this, push it. I know President Biden has sort of stated medical debt is a top-notch concern. It's a top policy area for the work. As far as what's going on, I'll go back to the charity care. And again, in this case, with a for-profit hospital, it seemed like they were trying to fluidly enroll people. And if I recall correctly, if it was 200% of FPL or less, they were automatically just entered into it, which the patient had to do nothing. They showed up as 200 FPL or federal poverty level or under, they were automatically in. I think 300% was they asked them if they wanted to be enrolled or whatever. They had to basically, they had to opt into that. But it seemed like a good way forward. I mean, I see that as potentially a thing. But again, with the high deductible plans, I mean, I was a former small business owner. So I certainly can appreciate that. You want to give your staff the best insurance you can afford, but for some business owners, I'm sure that is unfortunately a high deductible plan.
Okay, there was a question back there. I'm sorry. Let's go to this one first since the microphone's there.
Hello, I'm Ralph Lamberti. I'm an undergraduate senior in the business school here. And I just had a question about to what extent everything we're talking about is going to be done voluntarily, and then like what the role of the government is. There are just a lot of different stakeholders here, and some really serious issues that are very complicated and some lofty goals. So I was just wondering to what extent is industry going to make moves on this themselves, and what the role of regulation or legislation or enforcement would be in kind of pushing the envelope here?
That's a great question. Most hospital systems and provider groups really want to work with the patient and engage with the patient. So a lot of this stuff is new to the industry. As I said, in 5 to 10 years, the industry has changed a lot, where now you have a lot more patient engagement that is needed. And so a lot of it you will see is voluntary, and many hospital systems that I know of are doing more in terms of consumer education as well as outreach. And there are more and more social workers getting hired to help the patients. So yes, it will be voluntary, but yes, to some degree, some more things will have to happen.
Is there some hope based on technology? I know back when I was a collector, I mean, I had staff that did really, really well, and they weren't even collecting. They were basically just finding mistakes in billing and getting enormous payments that we probably didn't really deserve, but they were taking advantage of the leaks between the provider and the insurance company. And again, there are software companies, I think Epic Systems is one of the bigger ones. Like, if that flow is more real, near real time, the data flows better. It seems like that there's a direction there where technology could make the problem a lot less.
You would think that these $250 million systems would solve the issues, but if you actually go inside a system, unfortunately, I would say that they don't. They make it actually even more complex than it used to be, because now all the workflows are coming together. You're seeing like 75 line items on one bill, which gets harder for the billing office person. It's like these technologies are actually much smarter than the people who are handling these technologies. I mean, we can't keep up.
I should have known better.
So my vote is that industry do as much as they can themselves. Hank's organization is all about challenging private industry to bring solutions to bear. For sure, there's a lot of variability in our clients and in consumers, and so one size fits all is going to be tough if it's forced down. We're certainly in a hurry to bring innovation to bear. You're basically describing innovation. And if the innovation is about the consumer, puts them first, then I think you have some good solutions. But that's what we hope to happen. And again, through collaboration, maybe we can do it.
Okay, thank you. One final question in the back there.
I'm Chris Wagner. I'm at the School of Foreign Service, and I wonder about a big picture. So what kind of crucial components would an ideal healthcare system have for you? So if you were to start from scratch, or the other way around, so different countries have different solutions, and some are really praised for, others, they don't work that well. So if you had to start from scratch, so not fixing here, there, everywhere, and it's sort of managing, what would be some core components you would hope for a healthcare system would offer?
I would start by saying something that my team has not done in healthcare, but we do it a lot in other financial services, is we do sort of a worldwide scan. And again, we try to be humble and not assume that we can invent something better. We look to see what's going on elsewhere. I mean, there are some countries that are, in terms of financial services products, they're much more sophisticated than we are. I mean, and they're sort of great exemplars to look for. I think I'd start with looking at deep study of healthcare systems in other countries. Don't assume we have the best. I don't think anybody does. But look for models elsewhere to build a better system.
I am loath to redefine the healthcare system. I don't think, I would say that putting, I've said it so many times today, but putting the consumer first, encouraging people to do other things besides always going to the hospital. Okay, so someone asked a question that might have been around that. I recently went to the hospital, to the emergency room. I thought I was in bad shape. Turned out I needed one stitch, so it wasn't that bad. I shouldn't have gone to the hospital. There's plenty of other places I could have gone. And so maybe that's educating people about their options and about some of these other new things that people are doing.
Okay, well, thank you so much for being here. Thank you online for also attending. Thank you for your questions. And please join me in thanking this expert panel for being here today. Thank you all.
Absolutely.
Thank you.
Thanks, John.
Absolutely.